Good morning, everyone. My name is Robert Hersey. Happy Thursday to each of you, and on behalf of FATA, welcome to today's webinar titled Baby Boomers and Substance Use Disorder, a Growing Concern. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel. We will answer questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the audio connection panel. For computer audio, click the up arrow next to unmute, then click the switch audio connection panel. Click disconnect. Click the up arrow and switch audio connection buttons again, then click call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option. The access code and event password will be posted in the chat panel momentarily. You must be connected to the audio of this presentation as well as view it on screen to receive a statement of credit. We are unable to verify attendance if you are not connected to WebEx via your computer or a mobile app. Therefore, phone call only attendees are not eligible for a statement of credit or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through FATA. A statement of credit and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Completing the post-webinar evaluation is necessary to receive CEUs or to receive a statement of credit. Please note that the evaluation will close at the end of the day on Tuesday, June 17th, 2025. At the end of today's webinar, you will have 3 opportunities to complete the evaluation: a link posted in the chat, a follow-up email from WebEx, and an automatic web browser pop-up when I end the webinar. To complete the evaluation, you will first need to register or sign in to your FATA account. Please ensure your name and email address match the name and email you used when you registered for today's webinar. Information you provide FATA as part of registering remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your license or certification number when you register with our site. If you need assistance with account registration, logging in, or accessing the evaluation, fill out a contact form on our website or email training@floridabha.org before June 17th, 2025. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a statement of credit if you do not attend the entire webinar, and we are not permitted to provide partial CEUs. Statements of credit will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CEUs will be reported to CE Broker within the same time frame. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today will be Dr. Jason Hunt. Dr. Hunt has a career spanning clinical care, academic leadership, and national advocacy. He is a former professor and attending physician with the University of Florida College of Medicine's Department of Psychiatry, Division of Addiction Medicine. A graduate of the University of Illinois College of Medicine, Dr. Hunt completed his OB/GYN residency at the University of Louisville and completed a fellowship at the University of Florida. He is a nationally certified advanced alcohol and drug counselor and has served in key roles, including board member of the Alabama Alcohol and Drug Abuse Association, FORMLL, and Pathfinder. Dr. Hunt is widely recognized for his work in treating substance use and co-occurring disorders, with a particular focus on opioid use disorder during pregnancy. He has presented extensively at state and national conferences and currently serves as a peer prescriber mentor for FATA and the Florida Department of Children and Families. He also consults with the Opioid Response Network and is a co-author of Understanding Addiction: No Science, No Stigma, a book that reached number 7 on Amazon's drug dependency and recovery list. And now I would like to welcome our presenter, Dr. Jason Hunt. Dr. Hunt, I will turn it over to you.
Thank you, Robert, and good morning, everybody. And we'll just get started so we can get through this. It's a lot of information, and please feel free to ask any questions, submit them through the chat, and we will get to them either in the presentation or afterwards. So let's get started. Baby boomers may be more susceptible to developing addiction issues due to factors such as chronic pain, retirement, loss of social connections, and mental health issues. Additionally, older adults may be more likely to misuse prescription medications, which are much easier to obtain from their doctors in this population, or turn to substances in a way to cope with the challenges of aging. It is important for healthcare providers and caregivers to be vigilant monitoring and addressing substance use issues in this population. I have no disclosures and learning objectives. Hopefully we'll understand substance use and opiate use disorders for the baby boomer generation, explain how substance use disorder impacts the brain and the decision-making pathways of individuals using opioids and related substances, understand the concepts of medication for opiate use disorder and how treatment can support the individual's road to recovery, recognize the Food and Drug Administration's approved medications to treat substance use disorders and how they are used to treat opiate use disorder. So what is a baby boomer? Well, a baby boomer in general is a person born between 1946 and 1964. So what is addiction, or what is substance use disorder, the medical term for addiction? Is it a choice? Is it a weakness? Is it a physiologic dependence? Or how about a learning disorder? What about lack of willpower? Is it an amoral condition, or that age-old argument, it's a sin? Well, we know now it's a brain disease. Decades of neuroscience and research have revealed addiction to be a chronic brain disease that changes the brain. It changes its structure and function. And some of these changes quite possibly were there prior to the very first use. Addiction is treatable with a combination of medical treatment, behavioral therapy, and support. And also prevention efforts and treatment approaches for addiction are generally just as successful for this disease as well as other chronic diseases. The one thing that we don't talk enough about is that people do get better and treatment works. We spend a lot of time talking about the devastation and the deaths during and caused by the opioid crisis, but however, treatment does work, and we need to talk about this much more. There are approximately 73 million baby boomers in the U.S. today, with 5.3 of them living in Florida. Baby boomers are at higher risk of prescription and heroin overdoses compared to younger generations. Substance misuse often goes unnoticed in this age group, but according to SAMHSA, the use of illicit drugs by baby boomers has nearly doubled since 2002. The CDC data shows that the rate of overdose deaths among seniors has increased fourfold since 2002. A Florida Medical Examiner's report indicates that individuals aged 50 and over accounted for a majority of deaths related to certain drugs like oxycodone, hydrocodone, morphine, as well as alcohol and marijuana. They were also the second highest in deaths caused by fentanyl. Substance use disorders among baby boomers is a growing public health concern due to life transitions, chronic pain in this population, and medication and medical issues, as well as co occurring psychiatric mental health disorders. Next. As people age, they may experience more chronic pain and health issues, leading to increased rates of opioid prescriptions, which they in some ways and sometimes can be easily obtained by their physicians. We're doing much more these days to educate these physicians on the risk and the risk factors of these medications, and we're doing much better. And actually, the overdose rates from prescription pills has gone down and has kind of transitioned over to heroin and illicitly manufactured fentanyl. Long-term use of opioids by the baby boomers can lead to tolerance and dependency, requiring higher doses for pain relief that puts them at a much higher risk of overdose. Lack of awareness about the risk of long-term opiate use among older adults and inadequate monitoring by their healthcare provider can lead to prolonged and potentially inappropriate use of these medications. Genetic predisposition can increase an individual's susceptibility to addiction by influencing how the brain responds to alcohol and drugs. Variations in genes can impact the risk of dependency. As people age, their bodies process alcohol and drugs differently due to changes in the muscle mass and liver function, as well as brain chemistry. And this can lead to an increased medication interactions, falls, accidents, and cognitive decline or impairment. Baby boomers are at a higher risk of experiencing chronic health conditions such as mood disorders, lung and heart problems, and memory issues. Substance use can worsen these conditions and lead to negative health consequences. The effects of drugs and alcohol on the aging brain are not well understood, but older individuals may be more sensitive to these substances. Alcohol is the most commonly used substance among older adults, with baby boomers consuming more alcohol than in previous generations. Studies suggest that up to 14% of older adults misuse alcohol, which can have a significant impact on their health and well being. 78% of older adults who drink also take medications that interact with alcohol and negatively interact with alcohol. Binge drinking can have serious health consequences and increase the risk of accidents, injuries, and long term health issues, and can be just as dangerous as daily drinking. As they always say, I don't always get in trouble when I drink, but every time I've gotten into trouble, I had been drinking. So the binge pattern can be just as significant and just as serious as a daily somebody who drinks heavily and drinks daily. Next slide. And death rates from alcohol related causes have been going up since 2011 and rose by 18% from 2019 to 2020. Older adults are prescribed and use more medication than any other age group, including opioids for chronic pain. Misuse of prescription drugs amongst older adults can include taking larger doses, changing doses, taking someone else's medications, or using it for unintended purposes. Baby boomers are frequently prescribed benzodiazepines for sleep and anxiety, but these medications can also lead to dependence. The FDA just put out a recent warning about these medications and how to taper off and take people off these medications and switch them to safer medications with a less addictive potential. And these medications also have a black box warning when used with opioids. It definitely increases the um, chance of overdose mixing benzos with alcohol and or opioids. And older adults can often take multiple medications and may experience negative effects from combining prescription and over-the-counter drugs. Baby boomers are at a higher risk of dying from prescription drug overdoses compared to other generations, which is a significant cause for concern. You can see in the graph how the death rate and the mortality rate has increasingly gone up, especially over the last several years. Cannabis use is also associated with a higher risk of injury and memory issues. The use of cannabis among adults aged 65 and older has increased by 75% between 2015 and 2018. Next slide. The increasing potency of cannabis may lead to this increased risk, such as increased anxiety, depression, cognitive problems, and impaired motor coordination. Stimulant use, such as cocaine and amphetamines, is linked to anxiety, psychosis, high blood pressure, and rapid heart rate, which can be exacerbated in older adults. Older adults are more vulnerable to the increasing effects of cannabis as well as these other medications. Next slide. According to the Florida Department of Law Enforcement, there was 1,849 illicit drug deaths among persons older than 50 in Florida in 2020. And this slide shows the cocaine, heroin, methamphetamine, and the new drug xylazine that has devastating effects. Next slide. Aging is the natural process of growing older, which can lead to physical, mental, and emotional changes. As already mentioned, addiction is a chronic condition characterized by compulsive drug use despite harmful consequences. Older adults may be more vulnerable to addiction due to factors like chronic pain and loneliness. When aging and addiction coexist, it can create unique challenges, such as increased susceptibility to substance use and barriers to seeking help. It is important for older adults to seek help from healthcare professionals and support groups to address both aging and addiction and improve their overall health and well-being. Next slide. Addiction among baby boomers can lead to physical and mental health issues, isolation and loneliness, financial strain, relationship problems, legal issues, and even death. It is important for individuals in this age group to seek help and support if they are struggling with addiction. Next slide. Baby boomers with substance use disorders face severe health consequences, such as increased risk of overdose, respiratory problems, cardiovascular complications, neurotoxicity from chronic opioid and substance use. Neurotoxicity can affect the brain function and worsen conditions like dementia, actually increasing its progression. Substance use disorder can worsen mental health conditions like depression and anxiety in older adults, which are already common in this population. The stress of managing addiction can further deteriorate mental health much more rapidly. Next slide. Many older adults with opioid use disorder experience social isolation due to stigma and health challenges, while the economic impact of managing chronic pain and addiction can lead to financial strain. This includes the cost of the medications, the healthcare services, and potential loss of income due to disability. Between 2000 and 2020, drug overdose death rates for adults aged 65 and over increased significantly, with men experiencing a faster rate of increase than women. Men had a higher rate of drug overdose deaths compared to women in 2000 and 2020. For men, after increasing by 5% annually on average between 2000 and 2014, drug overdose death rates increased by 14% annually on average and more than doubled between 2014 and 2020. For women, drug overdose deaths nearly doubled between 2000 and 2009 and continue to increase at a slower rate from 2009 to 2020. The problem is this problem is continuing to get worse, and we know what's causing it, and we're having a very difficult time treating it. Education, access to healthcare is definitely needed to help combat this disease and this growing concern. Next slide. Age-related deaths among drug overdose deaths for men was 1.2 times higher for men than for women in 2000 and 2.1 times higher in 2020. You can definitely see from this graph how the increase in mortality continues to go up at a higher incline than in the past. And this is mainly driven by the opioid crisis and the prevalence of fentanyl. Next slide. So in 2020, adults aged 65 and over had the highest rates of drug overdose deaths involving synthetic opioids other than methadone. And some of the synthetic opioids that you may have heard about are fentanyl, tramadol, methadone, buprenorphine, carfentanil, and acetylfentanyl, and some other kind of chemically manufactured opioids that can be made easily in a lab. These synthetic opioids are often used medically for pain management, but can also be abused recreationally due to their potent effects. Next slide. Drug overdose deaths from synthetic opioids, particularly fentanyl, increased by 53% for adults aged 65 and over from 2019 to 2020. Overdose deaths involving natural and semi-synthetic opioids remained stable from 2017 to 2020, while heroin overdose death rates were stable from 2017 to 2020, after rapidly rising from 2011 to 2017. As you may recall, that's the time when the pills, there's the crackdown on pills. The pill mills were shut down in 2010, and people switched over to the cheaper and the more available form in heroin. And then in 2015, when the fentanyl became prevalent, we really saw a rapid rise in overdose deaths. Methadone overdose death rates for this age group have steadily increased as well since 2004. Next slide. So SAMHSA recommends yearly screening for adults age 60 and older and during major life changes. Multiple screening tools, and these basically all involve some sort of questionnaire or interview. There's the Audit C, Assist, BAM, CAGE, the NIDAS Quick Screen. Most people, probably the one they're more familiar with is CAGE, which stands for cutting down. If you ever tried to cut down, have you ever been annoyed by criticism, or somebody asked you or questioned you about your drinking or using and you became annoyed? Have you ever felt guilty about your use or things you've done while impaired? And then eye opener. Have you ever woken up in the morning and needed the pill or the drink to feel normal? And then the CAGE 8 is they adapted to include drugs. So it's really the same for alcohol and drugs. And then there's multiple other questionnaire type screening tools as well that are listed there. The alcohol use identification test, which is the Audit, the alcohol smoking and substance involvement screening test, which is Assist, the brief addiction monitor, which is BAM. I just went over CAGE, the National Institute of Drug Abuse, NIDAS Quick Screen, and then cannabis use disorder identification test. Next slide. So some DSM-5 criteria for substance use disorder or addiction may not fully apply to older adults because they are much more vulnerable, and they have a unique risk factors that may require treatment even without meeting all the criteria. So diagnosis also varies for those with a history of substance misuse, meaning the earlier in life somebody used versus those who develop problems later in life. And if we really to look closer at the diagnostic criteria, meaning how do we diagnose addiction or how do we diagnose a substance use disorder, there's 11 criteria, which are generally behaviors, and this is assessed by a healthcare professional. And it comes down to about 11 criteria, meaning asking the question or finding out in the medical history, are they drinking or using more alcohol or drugs over longer than they planned? Have they been unsuccessful at trying to quit or cut down? Have they ever had cravings or a strong desire to use or drink? Drinking that interferes with their responsibilities, either at home, at work, or at school. Continuing to use or drink even when it's caused problems with family and friends. Giving up social, occupational, or recreational activities because of our drug use or alcohol use, meaning we don't not as active as we used to be in things we used to like to do. Repeatedly using alcohol in physically hazardous situations like drinking and driving. Developing a tolerance to alcohol or drugs, meaning I need more of the drug or the drink to get the same effect or the effect that I'm looking for. and what is that effect that one is looking for. And then experiencing withdrawal symptoms such as shakiness, restlessness, nausea, sweating, depression, anxiety after stopping use. So 2 to 3 of those equal mild substance use disorder or alcohol use disorder. Answer yes to 4 to 5 of them equates to moderate substance use disorder or alcohol use disorder, and 6 or more is you're diagnosed with severe substance use disorder or alcohol use disorder. And it's this category that is equivalent to addiction. So 6 or more means you progress to addiction. So the severe substance use disorder is addiction. Somebody with mild or moderate, their brain might have not changed enough to actually qualify for addiction. That's why some people may be able to quit, why others can't. One of the hallmarks of severe substance use disorder or addiction is not being able to stop when, even despite harmful consequences or when things are going bad or causing problems. Next slide. Multiple treatment approaches, behavioral interventions, medical treatment, and then even holistic approaches. Next slide. Some of the behavioral interventions, cognitive behavioral therapy, you may have heard of it as CBT. This helps individuals understand and change their thought patterns and behaviors related to substance use. The purpose of CBT is to help individuals develop healthier coping mechanisms, improve problem solving skills, and ultimately lead to more fulfilling and balanced lives. Another is motivational interviewing. It's a counseling approach that helps individuals find motivation to make positive changes. The purpose of motivational interviewing is to help individuals explore and resolve ambivalence about their behavior change. It is a client centered directive method for enhancing motivation to change by helping individuals identify and resolve their own reasons for change. And then group therapy provides a positive support and shared experiences from peers that are in recovery. Medication treatment. Medications for opiate use disorder include buprenorphine, methadone, and naltrexone. Buprenorphine helps reduce cravings and withdrawal symptoms and is available in various forms. And since the last few years, has been able to be provided from any doctor in any doctor setting. Methadone, a little different. It's a liquid medication that can only be dispensed in a certified opioid treatment program and helps manage withdrawal symptoms and cravings. It's the main way these medications work is to manage the withdrawal, decrease their cravings, so they can get into more recovery-related activities. Now, Trexone is an opioid antagonist, means it's an opioid blocker. So it blocks the effects of opioids and is used for individuals who have already detoxed from opioids. It's also been around and used for alcohol for a long time as well to reduce the cravings for alcohol. Next slide. Other medications for alcohol use disorder are camprosate, disulfiram, and I already mentioned naltrexone. A camprosate helps reduce cravings and withdrawal symptoms. Disulfiram actually blocks the enzyme involved in breaking down alcohol. So it makes somebody feel really sick or almost like they're in, have a hangover once they have the first drink. And this kind of deters them from continuing to drink. And then again, naltrexone blocks the effects of alcohol, reducing the cravings. Next. So integrated care, which is the gold standard. Integrated care combines substance use disorder treatment with primary healthcare services to address addiction and other health conditions together simultaneously. Mental health services are also provided to address co-occurring conditions such as depression and anxiety. Inpatient rehab or rehabilitation or detox offers 24/7 care in a structured environment for severe cases. And then we have outpatient programs which provide more flexibility to individuals who receive treatment while possibly living at home. You may have referred to these and heard of PHP, which is partial hospitalization program, or IOP, which is intensive outpatient program. Both of those are outpatient programs. Next. Various holistic approaches, such as yoga, meditation, acupuncture, nutritional therapy, massage therapy, and other alternative therapies, can help manage stress, anxiety, cravings, dietary deficiencies, physical pain, and tension. Other approaches like art therapy, music therapy, and adventure therapy can also be beneficial and can be included into an overall recovery or treatment plan to help improve their overall well being. Next slide. Some addiction prevention strategies include education and awareness, building strong support networks, developing healthy coping mechanisms, setting boundaries and limits, seeking professional help, encouraging healthy lifestyle choices, monitoring prescription medication use, and encouraging open communication. These strategies aim to provide individuals with the necessary tools and resources to make informed decisions, cope with stress, and address their substance use issues early on before the problems get too severe. Support systems, family members should be involved in the treatment process when possible. They provide emotional support, visit during times of non use, and attend family support groups. Caregivers should have an understanding of the cognitive problems related to substance use disorders and recognize that addiction is a disease that requires treatment. They should also address any personal difficulties with a medical provider. Community resources include support groups such as AA, NA, other 12-step programs, senior day programs, and community coalitions. These resources provide support and services for individuals in need within their individual community. Slide. The role of healthcare providers? Well, providers need to accurately assess and diagnose substance use disorders using standard criteria like the DSM-5, which we went through a little bit earlier in this talk. This involves understanding the patient's medical history, current medication use, and any signs of misuse. Providers should prescribe medications or offer to prescribe medications like buprenorphine, methadone, or naltrexone when appropriate to manage withdrawal symptoms and cravings in substance use disorder patients. They should monitor the patient's response and adjust these dosages um, when necessary. Integrated care involves combining the substance use disorder treatment with primary care services to address all aspects of the patient's health, including co-occurring conditions like chronic pain, other mental health disorders like anxiety and depression, as well as medical issues like heart disease or lung disease, diabetes. All these can affect the outcomes and prognosis. Next slide. Educating patients about the risk of opiate and alcohol use, safe medication practices, and the importance of adhering to their treatment plan is crucial for helping them understand their condition and manage it effectively. Support and counseling, including therapies like CBT, MI, which we talked about, can help patients address the psychological aspect of addiction. Group therapy and support groups provide valuable peer support. Regular follow-up appointments are essential to monitoring a patient's progress. Adjust treatment plans and provide ongoing support to prevent relapse and address any emerging issues promptly. Addiction, substance use disorder, alcohol use disorder is a chronic disease. The problem in the past is we built this model where we expect people to go off for 30 days of treatment, and then when it doesn't work, we either blame the provider or the patient that they didn't want it or the treatment facility wasn't good enough. We would never do that with other chronic diseases like heart disease or diabetes. It takes long-term chronic care management, which can lead to full sustained remission. Collaborating with pharmacists, mental health professionals, and social workers can improve the care for seniors with substance use disorder by providing comprehensive and coordinated care through a team-based approach. Next slide. Some historical trends. Baby boomers grew up in a time of cultural shifts that led to more accepting attitudes towards drug use. As a result, this generation has higher rates of substance use compared to the previous generations. In the 90s and 2000s, there was a noticeable rise in the prescription of opioid painkillers, attributed to aggressive marketing by pharmaceutical companies and a focus on pain management in the medical practice. This led to increased long-term use and potential misuse among baby boomers prescribed opioids for chronic pain conditions. And as baby boomers age, they are more likely to experience chronic pain conditions that require pain management, leading to higher rates of opioid prescriptions among this demographic. Next slide. So some key takeaways. Rates of substance misuse in older adults vary widely and are increasing. Substance misuse in older adults is underrecognized and undertreated. A lot of this generation kind of picked themselves up by the bootstrap generation, does not seek help. We know how difficult it is to ask for help. And maybe with the baby boomers, it's even tougher. Older adults are affected by substances differently than younger adults, and smaller amounts of substances can have a much more impact and can be very dangerous for older adults. It is never too late to stop misusing substances, no matter one's age. Treatment works, especially when tailored toward older adults and their unique needs. Next slide. Some more advocacy efforts. Organizations like the AMA or NCOA advocate for policy changes to improve access to treatment and support for seniors with substance use disorder. They work to remove prior authorization requirements for medications, making them easily to obtain and treat these conditions, and enforce mental health parity laws. We're finally starting to see addiction, substance use disorder, this disease getting the same attention as other chronic diseases. We're not there yet, but we're getting closer. The National Opioid Action Coalition promotes community education and support through various initiatives, including education programs, medication take-back events, and assistance for individuals in recovery. Advocacy groups support harm reduction strategies, such as making naloxone widely available and implementing Good Samaritan laws to protect those who help in overdose situations. Harm reduction has kind of come around and almost carries a negative stigma. We've seen when people hear of harm reduction, and they almost automatically go straight to addiction and addiction treatment, or medications for opiate use disorder, which used to be referred to as MAT, which also carried a kind of stigma. But if you think about it, harm reduction is what's employed in all medical care. As a doctor, the very first thing I did in medical school was take the Hippocratic Oath, which was first do no harm. So all of medicine really revolves around decreasing the damage or the impairment caused by any certain disease. So harm reduction really is medication, or is medicine in general. Efforts are being made to provide support and resources for seniors dealing with addiction. We're starting to address this community more diligently and recognizing and getting them the help they need. Next slide. Thank you. Appreciate your time today. I hope I didn't take up too much of your time. I know it was a lot of information. So if you have any questions or concerns, please relay them to us and we'll get back with you.
Thank you, Dr. Hunt.
Go ahead, Robert.
I do have a couple questions in the chat, but I want to first say address something I've seen in the chat related to the webinar. I've seen several people ask, they're coming across as unverified, and they're asking if that affects their attendance. That does not affect your attendance. Unverified just means you are not signed into a WebEx account. If you're on the webinar, we have your attendance. So please don't worry if you see unverified next to your name. That does not matter in the long run. Dr. Hunt, I do have a few questions in the chat. I did have one person ask early on if there are additional considerations for the overlap in populations between baby boomers and veterans.
Well, we're treating them all the same. Now, veterans even have, necessitate even, with the high incidence of PTSD and other mental health disorders, that's a kind of a specialized group as well. But they suffer from generally the same considerations and the same risk factors, the chronic pain conditions that have allowed access to pain medications that led to dependence, that eventually led to addiction or opiate use disorder, and then also the co-occurring PTSD that we see in this population. So they're really treated the same. And the problem is access to care for both these populations. And one, the veterans, uh, some of the treatments are exhaustive and we don't have the treatment we need, and we're trying to get more and more. And then with the baby boom generation, a lot of them are not willing to go to treatment or don't think they have a problem because that generation has been fairly successful and self-reliant. So really reaching out to both of these populations, reducing the stigma of treatment and getting them adequate long-term health is key. So I would really, I would lump them together.
Perfect, thank you. There was another comment that says, I think this population gets overlooked because once they are in an assisted living facility or a skilled nursing facility, the focus is on their medical health, not so much their mental emotional health, which leads to the abuse of drugs and or alcohol. Is that something that you see?
Yeah, that's a great question and a great realization. That's true. And we see that even in treatment today with that population, that either the family member noticed some major changes, noticed that even the drugs that they were prescribed from their doctors, even at doses that they were prescribed, can start to have deleterious, much harmful effects as the patient gets older, as the brain ages. So medications that they could tolerate, say benzodiazepines or sedatives or opioids and pain medications, 10 years ago they were on the same dose and it didn't seem to affect them as bad as it did as they got older and as their brain started to age. And then the effects were much more pronounced, from memory issues to coordination issues. And then once they do reach out to get help, either from primary care or addiction specialists or into treatment, whether it's residential or partial hospitalizations or IOP, they do seem to revert back and really focus more on their physical complaints than they do the mental health complaints. So it takes a healthcare provider to really stay diligent in diagnosing their mental health issues, their cognitive and behavioral issues, their substance use disorder issues, and treating those kind of combined with the physical health, because you really have no physical health without mental health. But that's a very astute observation that a lot of this population are more focused on their physical health than their mental health, and a lot of it comes from the stigma associated with mental health going way back, that they don't recognize it or don't want to admit, or they may think they feel weak if they're talking about their mental health um, as an issue.
Thank you so much. What would your suggestion be for dealing with clients who are resistant to change? So you sometimes see in an older population, I'm this old, I can do what I want, it's my choice. And how would you combat some of that resistance?
I would say just staying on top of it and continuing to bring it up without, being too forceful or pushy. This generation, kind of wants to do things their own way. But the one thing about this generation is they typically do trust their doctors. They're not the WebMD generation. They're not the Google it. They're not the get it from their friends. That this generation, have seen their doctor. They trust their doctors. So the key is to continue to bring it up, because you'll have a lot of opportunities seeing this patient because of the other medical issues. So the main thing is to address it. So many physicians are scared to bring up, are they drinking too much? Are they taking too much of their pain medications? Are they getting something from friends? Are they using more medical marijuana that's leading to other drugs? So they just kind of leave it alone and they don't address it. There's been plenty of studies out there that shown that a doctor or a healthcare provider or a therapist that a patient trusts, if they bring up they have concerns about their mental health or their addiction, or that they're concerned about drug use or alcohol use, 76% will make changes. This is, if you catch it early as you start to see the problem. Now, if you wait till you get like 6 or more in that criteria I talked about, where they have severe substance use disorder or severe alcohol use disorder, where the brain has changed, where it's now more difficult to stop despite harmful consequences, it's tougher. But if this is recognized early that there's concern, studies have shown that people will change and they will trust their doctor, healthcare provider, therapist, or even family member. So the key is not to ignore it, not to look the other way, not to enable it, but to bring it up in a respectful, non-judgmental manner.
Thank you so much. What would you say, in your opinion, is the greatest need in addressing substance use disorder in this population? What is the greatest area of need in, treating substance use disorder?
I think it's adequate long-term care, whether if it's starts out in community-oriented care, whether it starts out in a detox that leads to some residential time, that leads to some partial hospitalization, which is more than 9 hours a week, that can lead, which is still outpatient, which leads to IOP, which is less than 9 hours a week. So you continue to step down and provide care. The problem is a lot of insurance policies don't cover this care, or they cover very minimal, or they don't cover what's adequate. So access to care, uh, covered care from insurance companies, and facilities willing to treat this population. We need more and more and more of all of it. And then healthcare providers willing to ask the hard questions and make the recommendations.
Thank you. How does substance use in youth impact the current substance use disorder in this population? Is there like a high correlation between substance use as, a young adult or a teenager and this age group?
Yes, and I kind of alluded to it a little bit during the talk, where a lot of this age group back, go back to the 60s and 70s, where drug use was more acceptable. Some of the substances were legal that aren't legal now, and they had an exposure at an early age. But then, whether if it's school, work, military, they stop, but they've already kind of primed their brain for it. But the bottom line is, the earlier the drug use, the more likely there's going to be a problem either at that time or down the road. So, and this population had exposure to drugs and alcohol, probably in a more acceptable fashion back in the day, whether if it was smoking, tobacco, or other illicit drugs. So yes, they're kind of were primed, and then as they retired, kind of resulted back to kind of their previous patterns or their drug use, or felt they could control it, and they weren't equipped. Their brain wasn't equipped, and they progressed even more rapidly. But the earlier the drug use, the more likely there's going to be an addiction. That's in every population.
Thank you. I have two questions that are somewhat related. The first is, other than consideration of family history, are there any other specific tests to uncover physical predispositions to addiction?
Well, family history is the main one. I mean, it's, if a primary family member, a mother or father, had an addiction or an alcohol use disorder, you're already at 50% likelihood. It doesn't mean you're going to get it at all. It just means be cognizant and recognize it. The main one, though, is childhood trauma or adverse child experiences that they have now. So any kind of questionnaire or history looking at the neglect, the abuse, socioeconomic issues, parents with an addictive disorder, divorce, anything that kind of increased stress to the brain of a child or adolescent puts them at more risk for developing not only addiction, but other physical medical problems as well. So we really want to recognize the trauma or the stress that somebody's experienced in their life, and this can be at any age. And everybody's stress is different. Everybody's brain is different. Everybody's ability to deal with stress is different. So one person's stress may not be as impactful as somebody else's. So, but recognizing that stress and that trauma and speaking out about it and not being ashamed to tell a provider, all that can, address that. And you can combat addiction more successfully for sure, and diagnose it and pick up on it quicker.
Thank you. And then the kind of follow-up question is, what are there any tests that can be done to determine changes in the brain? This person observed that evidence of change may help motivate somebody to change their behavior.
Well, there are, and they're starting to be used more and more. Now we've got, functional MRIs or brain imaging or brain scans that can show damage to the brain, but that really doesn't give us a clear picture. What cognitive testing really is more reliable in how much damage is done to the brain with their memory, their procedural memory, their cognitive issues. We can get a really good picture of what's going on in their brain from cognitive, neuropsychological, neurocognitive testing to see. And the good thing is, even late into age, the brain can heal, and that all can get better. There's exercises for it, but just stopping the drug use, getting into recovery, doing healthy activities, exercise, eating well, and then, you know, positive support groups, all that can have lasting positive effects on the brain and brain changes in somebody. So, you know, good therapy, but there is cognitive behavioral testing that can be done by psychiatrists, psychologists, and then other independent people as well.
Thank you. And there's a question, what about genetic testing for medication response? I'm not sure where the question is going, but I think maybe, to see if medications to treat substance use disorder will be effective. I'm
You
thinking
know,
maybe that.
that's there's more and more of that out there, but anecdotally, meaning I've seen patients come in and we looked at, they spent the money and they've got the genetic printouts of what medications are supposed to work and what's not to work. And then we avoid the ones that are not supposed to work. And then down the road, we try that medication that the genetic testing said wouldn't be as effective, and it's very effective. So it's not an end all be all. So you really have to kind of, I don't want to say take it with a grain of salt, but I think it can give you a direction on what to start, what to try first. And they're probably going to get better at it, because what they're looking at is how fast the body metabolizes these medications, meaning if they use them up real quick, you're not going to get as effective a dose versus somebody who the medication sticks around longer, so you need less dose. So it's definitely an aid, but I wouldn't, make my whole treatment plan depending on a genetic medication profile, if you will.
Awesome, thank you. I want to turn it over momentarily to Diana. Diana is a staff member here at FATA, everyone who works with our peer prescriber mentors. And Diana, I know you're very knowledgeable in this subject area. I want to see if there's anything that you might want to throw in that, would help participants, or any questions you may have as you've worked closely with Dr. Hunt over the past couple years.
Yes, Dr. Hunt, I know that during the presentations that we've given over the last few months in this topic area, one of the questions that has come up has been treating, this population. A lot of them have a co-occurring disorder. Do you start with looking at the other medications before you start treating the substance use issue? Can you just give a little better understanding about how, especially most of these people are going to be on benzos or sleep medications? Where do you start when you look at treatment for the substance?
Yeah, now they're coming to realize, the addiction field's always known how bad benzos are. There's really no place in medicine for benzodiazepines at all. Maybe very short-term panic attacks, less than a week, but anything longer than 6 weeks of a benzo is going to cause way more damage than it's ever going to help. And in my opinion, those medicines will probably be off the market one day. And it sounds like with the FDA and their recommendations to take everybody off of them, that's probably where we're headed. But as far as the mental health, because really is what is the cause of the anxiety, and the benzos are not going to help it. It's just going to make the anxiety worse over time, especially when you try to come off the medication. I always say these medications don't treat the symptoms. These medications like benzos, like Xanax, cause the symptom that needs the medication. Uh, so so the key is treating the underlying depression, anxiety with non-addictive medications, using multiple approaches, from some group therapy to individual counseling to the safer medications, but to address them both simultaneously, because it's really what comes first, the chicken or the egg. A lot of people were probably self-medicating their trauma, their depression, their anxiety with medications going way back, and it was really a mental health issue that developed into a substance use disorder, versus somebody who just started using drugs out of the blue, because nobody uses drugs as a child or adult or to get high. They use it to feel better, to feel normal. And then it can also lead to their mental health disorder. So the key is really acknowledging, taking good history, and treating them both together, really as one condition. Because
Great.
looking now, co-occurring disorder, is really more of the rule than the exception.
Yes. All right. So, in your current position there, and in your prior history at UF at the treatment facility there, what were you seeing or have been seeing related to this population when they're seeking treatment? Are you seeing more of it being, street drugs, prescription drugs, alcohol? In your context, what are you seeing in the practice right now when in this age group?
Alcohol is generally number one, pretty much across the board. One, because it's so prominent and you can get it anywhere. Um, After that, you're probably pain medication. After that, probably benzo. And what's coming up is cannabis or marijuana use. So, and usually some of them really, in this, especially the baby boom generation, a lot of it started after retirement. They were so focused on their job, their career, their family. And then once they retire, um, they've had these drugs or prescriptions or marijuana or recreation that they've managed, that after retirement seems to get out of control fast. And a lot of times they enter treatment even older when a family member finally recognizes their decline and that there's a problem. And usually it's gotten pretty obvious before they seek help versus the matriarch or the patriarch of the family. They're probably not being brought into treatment when they're still semi-functioning, but when it gets really bad, that's usually when the family reach out. And unfortunately, that's when it's the most difficult to treat, the most expensive to treat, when the problem's been around so much longer than it could have been and not addressed early.
All right, great. Another question, I know we kind of touched on it earlier, was working, collaborating or working, trying to work with the general practitioner, or their NP, their physician, because we don't, as you stated, this population really looks for guidance from their personal physician. So what are your thoughts again about some of the clinicians that are on this call with us today, how to create a relationship or look at creating a relationship with a general practitioner to help address some of her senior patients that she might, or elder patients that he or she might be seeing?
Well, like I said, most patients are very trusting of their physician and have a good therapeutic alliance. So the key is to address it with that patient if there are concerns. And a lot of times the concerns don't come up until routine lab work and their liver enzymes are up. And then they may or may not ask them about their drinking patterns, and the key is be non-judgmental and to not push them or question them or accuse them of being dishonest, but to continue to bring it up in routine visits. And once the doctor actually expresses concern, especially for their health, most of these patients, they want to be healthy and they're going to listen and they're going to look at themselves as, maybe there is a problem. And then reaching out to, the organizations that deal with this, or there's, treatment providers that deal specifically with addiction now with the addiction medicine physicians, and that will collaborate. We collaborate greatly with the patient's primary physician and set up conference calls and kind of can be the bad guy, if you will, but just having them make that connection to where they can reach out for support or help and work in collaboration and integrated care is usually gives the best result.
So with the growing populations of 55 plus communities in the state of Florida, like, from the Villages area to Margaritaville and other areas that are popping up around the state, do you think and feel that there's going to be an increased need for some specialized services with this population, from AA to treatment? What are your thoughts on
Oh
that
yeah, and
area?
we're already seeing it, and we're seeing this population, dive headfirst into it and accept it, and creating these larger support groups and AA meetings and meetings within these communities, a lot more resources, a lot more people in recovery. So there's a lot more unity involved, and a lot less shame and a lot less guilt when people are more open about that and speak up in their community centers, and they have AA in these communities, and it's becoming more and more prevalent without a doubt, and it's reaping rewards.
So there is one more question, I think, from one of the audience members. They had sent in, do you know if nursing facilities monitor the use of giving anxiety or sleeping meds for their patients?
Well, I mean, I know they do, but I know it's a big problem because a lot of times they enter these facilities, assisted livings, depending on the level of care, already on these medications and been on them for years. And it's so difficult to take somebody off that's been on these medications for years and years. So, probably not a lot of effort to get them off, because it would be almost impossible in that setting without, putting them into a real treatment center for long-term residential care, and the resources to cover that and different things. So it seems to me that a lot, um, the few we've gotten out of that population, even with UF and the UF Psychiatric Hospital and things, were family members that noticed such a decline when they went to visit their aging parents and brought them in for treatment. And again, at that time, it's very difficult to treat.
Mhm. All right. Well, thank you, Robert. I'm going to turn it back over to you.
Absolutely. Thank you, Diana. Thank you, Dr. Hunt, for your time and for the wonderful information. I know it's very helpful to our participants in today's webinar. One thing I'd like to say before I jump into this conclusion, again, I've seen a couple of questions pop up throughout today's webinar about the word unverified next to your name. That is not a problem. If you are on the webinar, your attendance is verified. That is just saying that you're not signed into WebEx. It is not an issue as far as your attendance is concerned. We have included Dr. Hunt's contact information, so you can contact him with any further questions. Please note a couple of business items before we conclude today's webinar.
Robert,
Yes.
there is one more question.
Yes.
What is a replacement for benzos for anxiety that you might recommend, Dr. Hunt?
Well, it's mostly, we treat anxiety just like we treat depression. It just depends on, um, those medications, along with the other therapies that go with it, are beneficial. And so, since the benzos, like I said, create more anxiety once they've been started, especially when they don't have them, that we treat with pretty much all the SSRIs, the new SNRIs, which is serotonin and norepinephrine reuptake, and they're coming out with more and more that have less side effects. But usually that with the mental health therapy is usually the best approach, because even though the benzos may seem to work in the short term, and there's no doubt they do, but the potential risk greatly outweigh the benefits of those medications long term. So we really need to work on all the other antidepressants out there that really do treat anxiety as well.
I see this person had a follow-up question. It says depression med question mark. Not sure if I understand the question, Dan, if you want to clarify. Depression med replacing benzos, Dr. Hunt.
Yeah, but I mean, benzos just shouldn't be used really for any situation for the most part. Like I said, even now the FDA is recommending pretty much you come off of them because of the damage they can cause. Problem is, once somebody's been on them, their brain is so dependent on them. And psychologically, the person thinks they're the only thing that's going to help them, and getting that person off those medications is so difficult because they don't see what's coming down the road and the consequences of long-term use of these, especially their memory, their cognition, and they don't even recognize how much of a decline their brain is in until it's way too late. So the goal is to get people off these medications and use the other antidepressant anxiety medicines because they're both the same thing. It's really kind of replacing, but replacing that addictive medication, that severely addictive benzodiazepine with a more stable medication, that antidepressant, anti-anxiety. They're really the same medications. They were labeled as antidepressants, but it's still an anti-anxiety medicine. Because they're really stemming from the same mental health issue. So it's really going back to using that type of medication is much, much safer than a benzodiazepine is.
Thank you, Dr. Hunt. I have posted the link to the evaluation in the chat panel. I've just posted it again. Additionally, when I end today's webinar, your browser should populate a message that looks like this. It says the host or presenter would like WebEx meetings to open a website on your computer. If you click continue, you will be automatically redirected to the evaluation. This is not spam. This is WebEx trying to automatically redirect you. So click continue to automatically redirect to the evaluation. To complete the evaluation, you must sign into your FATA account. If this is your first FATA webinar, you can register for an account at no cost. You may do so by clicking haven't registered yet underneath the sign in menu. Please use the same email address you used when you registered for today's webinar when you set up your profile in FATA system. This is the only way for us to connect your attendance at today's webinar to your evaluation completion. For CEUs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the Professional Information section of your profile. You will get a third opportunity to complete the evaluation through a follow-up email later today. The evaluation will close at the end of the day on Tuesday, June 17th, 2025. If you need assistance with registering for an account, logging into your account, or completing the evaluation, you can fill out a contact us form on our website or email us at training@floridabha.org. As a reminder, we do not email statements of credit. Instead, once we verify your attendance and completion of the evaluation, a statement of credit will be posted to the professional development section of your profile in your FATA account within 30 business days. You must have attended the entire webinar and completed the evaluation for a statement of credit. We are not permitted to provide partial credit. The recording and materials used in today's webinar will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. Thank you again, Dr. Hunt, for your time and for answering all of our questions. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone, and please hold for the evaluation.